Nearly 200,000 ACL injuries occur every year. These horrible injuries can abruptly end an athlete's season. Thankfully, because of advances in the medical sciences, we can now repair and treat ACL tears. Two common reconstructive procedures include the hamstring graft and the patellar graft.
We're better than you, and we know it.
Oh, Lord. I was in a 6-month coma.
In this presentation, we will examine one ACL tear injury, the case of Kyle Schwarber, and we will also take a look at hamstring tendon grafts as a means of repairing an ACL injury, and we will also look at the cons of the patellar form of treatment. In doing so, we hope you see why we think the hamstring tendon graft is the way to go and not the patellar.
Left center, Schwarber. This could be trouble. Got to get over there. It drops in. He collides with Fowler. And Segar's almost at full speed. And he collided with Schwarber out there. That left leg.
No! God!
No!
No! Where's the lamb sauce?
In order for us to calculate the amount of force exerted on Kyle Schwarber's knee, we had to make an educated guess as to what was the final velocity that Dexter Fowler was moving at the moment of impact. That being said, we used the formula for momentum as we can see here. Force times the change in time is equal to the change in momentum. The change in momentum is equal to the mass of Fowler times final velocity minus the mass of Fowler times the initial velocity. By knowing the mass of Fowler being 88.45 kilograms, the final velocity being 6 meters per second, and also the amount of time making contact with Schwarber being 0.2 seconds, we went ahead and plugged into the equation and solving for force to find the result to be a total of 2,653.5 newtons, which is quite a lot.
Just going through the anatomy of the ACL is one of the four main ligaments that hold the femur and the tibia together. It attaches to the anterior side of the tibia and the posterior side of the femur. Its main job is to prevent anterior translation of the tibia, excessive internal rotation of the tibia, to prevent hyperextension of the knee, and to also restrain excessive external valgus forces.
Alrighty then.
Symptoms of an ACL injury often include a loud popping coming from the knee, a severe onset of pain, the inability to continue activity, and swelling and loss of range of motion. The knee also becomes unstable after the injury. The most common way the ACL can be injured is a sudden stop, a sudden change in direction, or often in contact sports.
Okay, that's cool. I get it, you know.
From the Journal of Knee Surgery, there was a recent publication about the motion analysis of the ACL. The investigators' goal was to synthesize information on how motion analysis can contribute to the identification of risk factors that may predict the relative risk of ACL injury. In their study, they've conducted a 3D motion analysis of 205 female athletes during their landing phase of a jump. From the 205 female athletes, 3D motion analysis helped identify individuals who might be in a higher risk of an ACL injury. These individuals had a higher knee abduction while landing, a decreased knee flexion, an increase in hip adduction, and a greater trunk instability. All these individuals had a higher relative risk of an ACL injury from these specific traits. In this figure, the researchers tested two cohorts of 205 female athletes. The researchers analyzed the athletes during a drop vertical jump. The first cohort showed a 20.9 chance of an ACL injury risk through excessive frontal plane torque, while the second cohort showed a 12.1% chance of an ACL injury risk. The interclass correlation coefficient for peak knee abduction moments was 0.931, which shows there is a positive relationship between knee abduction during a drop vertical jump.
Oh. Oh, is that so?
Some possible explanations for an ACL injury risk might be poor hamstring to quad ratio, lower peak strength to body mass ratio, and poor active and passive restraints. Poor hamstring to quad ratio typically means during the landing phase from a vertical jump, there is an increase in knee extension, which causes an excess in anterior tibial translation, which is typically termed for a higher ACL strain. This neuromuscular preference of knee extension over knee flexion during the stabilization of the knee during the landing phase of a jump is termed as quad dominance. Quad dominance can lead to lower flexion angles upon landing, which indicates less time and less movement to absorb the impulse generated from landing from a jump. This impulse leads to greater joint force generation, which is an increase in ACL strain. The next possible explanation is lower peak strength to body mass. This typically means the individual's ratio of strength of their musculature to their body mass is typically low. This risk factor might increase the chance of an ACL injury because it might increase the risk for frontal plane abduction torque. And finally, poor active and passive restraints of the ACL. This means the body's passive response to stabilize the knee joint to prevent anterior translation of the tibia, which is typically the ACL's job. This active/passive restraint insufficiency might increase the risk of an ACL injury due to higher frontal plane abduction torques. This MRI image on the left shows the side view or sagittal view of the ACL. The left image shows a normal ACL, while the right image shows a torn ACL. A typical torn ACL might be a little more white in an MRI image than the normal ACL because the bright white fluid shows that it's torn. The image on the right is an arthroscopic view of the ACL, and this image also shows that it's torn. The material properties of the ACL is quite brief. Since it's a ligament, it contains type 1 collagen, elastin, water, and calcium, and it also contains fibroblasts. Type 1 collagen is typically termed for its strength and stiffness. Glycation has a major effect on strength and stiffness from the cross-linking of the collagen. Typically, these collagen fibers are also crimped to allow elongation of the fibers before tensile stress is applied. Elastin contributes to its resilience and stiffness of the ACL. It's the last defense in preventing a rupture of the ligament. Looking at the load elongation graph, the force that was transmitted on Schwarber's ACL was 2,653 newtons. This surpassed his ultimate load of 500 newtons. Since Schwarber's ACL was ruptured, it can be said that the ACL reached its failure point.
No, Kelly Clarkson!
By looking at both the patellar and hamstring graft, we took a look at the pain assessment between them and wanted to see the comparisons between the two. In a study done by John et al. In 2016, 70 patients underwent ACL reconstruction surgery using both the hamstring graft and the patellar graft. There were a couple of things recorded: pain right after surgery and then 3 days after. Also the hours slept, patient satisfaction, reported breakthrough pain, and calls to the physician. In the bar graph to the left, we see that the percentages are higher for patients reporting pain that underwent the patellar surgery. Starting right after surgery up until 3 days after, it is always higher for the patellar graft. In the table to the right, the mean pain scores are underlined in red to show the difference, and we can clearly see it is higher for patellar all the way down the table when compared to the hamstring graft. The graph to the left is showing the sleep disturbances between the two groups, and although it might seem like they are almost the same, the patellar graft is on top for nearly all the times it was recorded. The graph to the right is focusing on the patients who contacted their physician and without a doubt shows the difference between those people who went with the patellar as compared to those who went with the hamstring graft. Impressively, 1 day after and 3 days after, 0% of the patients contacted their physician for the hamstring graft surgery. This graph is pretty much summarizing how much the patients were satisfied with pain management after they underwent the surgery. Once again, the patients who received the hamstring graft had a much higher patient satisfaction as compared to those that received the patellar graft surgery.
Well, we're waiting.
So now we wanted to compare the risk factors with time. That is, you undergo either one of the surgeries, but the question now is, what are the chances that you will tear it again as time goes by? Based on a study done by Lays et al. In 2011, 90 patients received the patellar autograft and 90 patients received the hamstring autograft. There was then a 15-year follow-up after the ACL reconstruction. By looking at this graph, we are looking at the risk of rupturing the contralateral ACL. We see by the circled region that there is a significant difference. In the 15-year follow-up period of this study, there was a total of 11 out of the 90 patients rupturing the contralateral ACL with a hamstring autograft, and a total of 23 out of the 90 rupturing with the patellar autograft. That being said, by going with the patellar autograft based on the study, the chances are statistically significant to say that you have a higher chance of rupturing your contralateral ACL as time goes by. In order for the surgeon to harvest the graft from the hamstrings, it is accomplished by separating two of the three tendons connecting the hamstrings to the tibia, those two tendons being the gracilis and semitendinosus, by sliding the tendons through a device called a tendon stripper to complete the harvest.
Are you okay?
I'm fine. I just threw up in my mouth a little bit.
In this part of the procedure, the surgeon then creates the tunnels. As you can see in this animation, the surgeon uses guide pins and reamers to accurately drill the tunnels at the anatomic insertions of the ACL, both in the tibia and femur as shown here. Now the surgeon inserts the grafts. The femoral end of the graft is attached to a toggle device that once inserted and rotated will hold the graft into place at the femur as shown here, and this is called suspensory fixation. The tibial end is attached using a guide pin and a screw, and this process is called interference fixation.
Do it!
In a 2007 study, J. Linklater et al. Found that hamstring tendon grafts resulted in decreased harvest site symptoms and radiographic arthritis. Through the use of an arthrometer, M. Wagner et al. Found that patellar grafts resulted in a larger anterior translation compared to hamstring grafts. This is not ideal, as a larger anterior translation could result in instability and impaired function of the ACL.
What? Bro, what are you talking about, man?
Additionally, R. Gupta, in a 2016 study, concluded that patellar grafts are associated with morbidities such as knee pain, nailing pain, increased risk of fracture, rupture, and even osteoarthritis. In addition to patellar grafts resulting in larger anterior translation, Goldblatt et al. Found that patellar tendon patients found themselves with greater extension deficits, sometimes more than 5 degrees. That was a lot of information to grasp, but we hope you now can see why we think the hamstring tendon is a way to go when it comes to dealing with an ACL tear, such as that of Kyle Schwarber. To us, the hamstring tendon is a clear winner here. As for the patellar graft,
I award you no points, and may God have mercy on your soul.
Okay, a simple wrong would have done just fine, but